Hello everyone, my name is Gao Yuan and I'm from the Shengjing Hospital of China Medical University. Today we are going to learn the auscultation of the lungs. So in these parts we have 3 parts. The first one we will revision of lung anatomy, and second, how can we prepare for auscultation, and the third one is the breath sound. So when you start the auscultation, you need to know the lung anatomies. You want from the auscultation to find something wrong with the patient's lungs. Maybe there is inflammations and COPD or asthma. So this is our lungs. We have larynx, trachea, and the 2 lungs. And from the front side, we see our trachea in the middle, and they bifurcate to right and left bronchus, and also to the bronchioles, to the alveoli. And from the front side, we will see 2 lungs, the left lungs and the right lungs. The left lung have 2 lobe, the supra lobe and the inferior lobe, but the right lung has 3 lobes. The right upper lobe and also called right superior lobe, and the middle lobe and the inferior lobe. So we know that there are 3 lobes of lungs. We try to find if there's something wrong, we can have a position of where it's wrong in the lungs. And this is the posterior part of our lungs. So we from the posterior, we see most of the inferior lobes of both lungs. So when you do the auscultation, you put your stethoscope on the lungs or on the trachea or bronchiovascular. You put on the lungs to hear what is wrong from the auscultation. So how to prepare for auscultation? Like if you are in a clinic or you are in a respiratory ward, you want to do the auscultation. First, you need to ask the patient to breathe deeply through their mouth, and the doctor needs to listen from the front to the back. Normally, they are in the sitting positions and move from left to right, side by side, and from the top to the bottom. So we can compare lung sounds at each levels, and the auscultating from the back will often result in clear lung sounds. So when the stethoscope is placed in the right position, it will avoid unwanted noise from other body processes such as gastrointestinal activity. So if you place the stethoscope directly on a bone, you will never hear anything. So for the posterior part, you want to avoid listening over the scapulars. So you ask the patient to cross their arms on their chest and lean forward. This pulls the scapula apart, exposing more lung are for auscultation. So this is the stethoscope. We put the diaphragm on the lungs. So for auscultation, you need to listen carefully for the breathing patterns and the sound characters of your patient's respiration. So from auscultation, you need to pay closing attention to the duration, intensity, pitches, and timing of breath sound in the recycle. So we have a lot of auscultation sites. So this is one from anterior part, the other is posterior part. So from the anterior part, you will hear the number 1 trachea, and the second and third is the upper lung field, and the middle lung field, and lower lung field. And from the posterior part, you will see the superior long field and middle and lower, and also they need the sixth and the seventh is the right or left cosphenic angles. So when you do the auscultation, you need to do the order. So breathe through the mouth. You listen from the anterior part, from the number 1 to number 2 to number 3, and from the anterior to posterior, top to the bottom, and side by side. So you listen all the lungs areas to find where is wrong. So from in these sections, we'll learn the breath sound. We mainly learn the normal sound. We have normal sound, abnormal sound, and also we have adventitious sound. For the normal sound, we have trachea sound, bronchial sound, bronchiovascular, and vascular sound. So abnormal is the sound is absent or decreased, or there is in the vascular part you hear the bronchial sound. And also we have some adventitious sound like crackles, wheeze, ronchies, stridors, and pleura. So the normal breath sound generated by turbulent airflow in the upper airways and the large airways of the lungs. It also, the frequency is 200 and to 2000 Hz. As the sound is transmitted to the lungs, it gets deadened. Higher frequencies are lost, and a softer, lower pitched sound is heard. It's like 200 to 400 Hz. In the small airways, airflow is laminar and slower. Turbulence and sound cannot develop. Smaller airway and alveoli are therefore a filter and not a source of sound. Thus, the term vascular breath sound should be replaced with normal breath sound. So for the trachea breath sound, the character is like a tubular. It's also called tubular sound. It's like blowing hollow or tubular qualities. It's a expiratory sound, longer in duration than inspiration. And also there is a distinct pause between inspiration and expiration. And the fourth is expiration higher in pitch and intensity. So normally heard over the larynx, trachea, or lower cervical vertebra. It is produced due to in and out movement of air through the narrow aperture of the glottis. So low pitch of sound during inspiration is due to glottic aperture being wider during inspiration. So for the bronchiovascular breath sound, it is intermediate in character between vascular and tracheal. Expiratory sound is louder, longer, and higher in pitch than inspiratory sound and display as a hollow character. Normally heard over and around the upper part of the sternum near the third and fourth dorsal vertebrae. Arises when normal air-containing lung tissue is interposed between a larger bronchus and the chest wall, thus combining character of both vascular and bronchial breath sounds. So the vascular breath sound, classically believed to be produced due to distension or separation of alveolar walls by inrushing current of air. Others believe that laryngeal sound, while traveling down the bronchi into the alveoli, gets modified through addition of sounds produced by passage of air from the narrow terminal bronchiole into the wide vestibule, producing rasping quality. Actual duration of expiration is slightly longer than inspiration, but the auditory component is much shorter as the elastic recoil of the distended lungs is maximal at the onset of the expirations. So for the normal breath sound, we have full breath sound. They have difference in the inspiration and expiration duration, the ratio. So first we have trachea breath sound. The inspiration and expiration is equal. It's 1.1. And the bronchial breath sound, the inspiration is shorter and expiration is longer. It's like 1.3. And for bronchiovascular breath sound, it's 1.1. And for the vascular breath sound, and the inspiration is more longer than 3.1. So normally we hear the most of our lungs, we hear the vascular breath sound. So we see the green position is a trachea breath sound. It's upper in the clavicle. And the purple one is bronchial breath sound. And for the blue ones, we hear the bronchiovascular sound. And in the orange part, if you put a stethoscope, is the vascular sound. So we hear most part of our lungs, we hear the vascular sound, but in some special site, we will hear the tracheal, bronchial, and bronchiovascular sound. So for these classes and this part, we learn the normal breath sound, and they are different. So the quality of normal breath sound, they have four kinds of breath sound. The first one is trachea, the next one is bronchial, and the third is bronchiovascular, and the fourth is vascular part. So trachea sound is very loud, high pitches. It's like tubular sound. So the inspiration and expiration sounds are equal. It's heard over the trachea above the subclavicle notch. And for the bronchial sound, it is loud, relatively high pitch. Inspiration sound shorter than expiration is 1.3. So it usually heard the position to hear the sound is over the manubrium, just above the clavicles. And the third is bronchiovascular sound. It is a medium pitches sound, loudness, and it is intermediate pitches. And usually the inspiration and expiration sounds is equal. It usually here the position to hear is in the blue part. It's in the first and second intercostal spaces next to the sternum and between the scapulars. So for the orange part is the most normal. Most of all, we hear the auscultation sound is vascular sound. It's soft and relatively low pitch, and the inspiration sound longer than expiration. And you can hear this sound most of the lung field. So this is all the number one part of auscultation. We hear the normal breath sound. We have four sounds: trachea, bronchial, and bronchiovascular, and vascular. And you need to pay attention where to hear the sound, how is the inspiration and expiration ratios. So this is all for this part. And thank you for your attention.